Hello, everybody who stayed around. Thank you. So I have two choices. I either dance up here to keep you awake, because after lunch, of course, the gut is going to slow us down a little bit, right? Or, well, who wants to see me dance first? I am not going to dance. But I'm going to take a little bit of a different approach. I would like to try, so if our people with microphones can be ready for me, I'd like to make this a little bit more interactive. That way you won't fall asleep on me, okay? Today I want to talk about the aftermath of COVID, even though I'm not sure it's the end, is it? We're kind of hoping so, but it's changed a lot in terms of how I do things. And at the same time, I know that it's affected all of us in many different ways. So I've made a list of some of the things that we've seen as differences, and I think probably you could help us understand as the clinicians that are in the room. You could probably help us understand what things have changed for you. So if you do have opinions, I'm going to ask you to share them as well, okay? So let's first start with management of Parkinson's. I've heard from many of you that there's less access to your clinical team, right? Services aren't as available. Sometimes things aren't done in person, and although you should be seeing your neurologist at least every 6 months, if not more than that, more frequently, things have changed, right? You're waiting for 9 months, sometimes 12 months, or I've heard that even some people locally in town are saying, well, you don't really need to see me more than once every 2 years, and that is a challenge. So we have to figure out ways to be able to help, and you also have to be better advocates for yourself so that when you do have that appointment is not a 5-minute, here's your prescription and out the door you go, right? And of course, from the other perspective, it's important to remind you and to think about this. Neurologists and the clinical teams are also overworked. They're trying to catch up. They're dealing with many patient populations, not just Parkinson's in some cases, and it makes it a very big challenge. And one of the biggest changes, of course, is the fact that we're doing a lot of things online. And online is a challenge because unless you're going to speak up for yourself and say what things you're experiencing within your own home, online, we only get to see your face. So it makes it very difficult to see what other symptoms, potentially side effects, and those sorts of things you might be dealing with. So it makes it very difficult for us to assess, makes it very difficult to observe the things that we might catch, like increased tremor in your hand if we can only see your face on a video screen. So this is where my segue into research comes in. We had to think outside the box as to how we could actually assess people online, and we're trying to find better ways to do this. Some of you I know were involved in these studies where we were in the midst of doing exercise interventions where we normally assess people before the exercise program so that we get a sense of what your symptoms are like. You go through the 3-month exercise protocol, and then at the end of the program, we would reassess to see if the changes in symptoms, if you've benefited from the exercise or if you haven't. And of course, in the midst of all of this, COVID happened, which meant that we couldn't do these assessments in person. One of the things we ended up doing was trying to figure out a way that we could still do assessments online, but be able to predict the UPDRS is the assessment that usually your neurologist does. Everybody will remember doing these types of things in clinic with the neurologist. So that score, we've come up, and some of you will recognize the name Kishori Sangara Pillai. She's a former master's student. She's now doing her PhD. And she came up with an equation, which we've coined the Almeida saying equation, where you can actually, from the online assessment, be able to calculate what your total unified Parkinson's disease rating scale score actually would be. This is an important tool for clinicians to use because, of course, if you have that total score, sometimes that helps dictate for a neurologist, does there need to be a change in medications? Are there side effects? Are certain things responding to medications and are some things not responding to medications? So this is one of the things that we've come up with to sort of be able to help with this situation. The second thing I wanted to go through, and I'm going to ask that if you have comments on this would be the point for you to speak up. Obviously, management is one thing, but the other question is always, is the progression changing as a result of COVID? And we could answer this from multiple perspectives. The first question, of course, is do the symptoms of Parkinson's get worse because of COVID? And it's a difficult question to answer. For many of us, we are less active because we were limited in what we were doing. And if you're limited in what you're doing and you're not getting out of your house or you couldn't go into restaurants, in that time period, of course, that limited activity can potentially, because of that lack of activity, cause things to feel like they're getting worse. At the same time, as I said before, if you're not seeing your clinical team as often, there's another challenge there because maybe the symptoms are not being managed the same way that they would have been in the past. One of the big things that we've noticed is cognitive decline. The lack of social interaction and being able to get together in groups like this or the support groups that are run by PSSO across southwestern Ontario, to be able to do those types of things in person and interact with people face to face. And it's great to be here face to face. We were actually talking about how 2 years ago when I would have done this, we sat in a little room and we videotaped everything to be able to do the conference. But that social interaction is very important. So as we saw patients online over the last 2-3 years now, probably the thing that we've noticed more than progression of the motor symptoms is cognitive decline. Memory issues, issues with medications, whether we know that the medications are working the same way, monitoring of side effects of the medications has become a bigger challenge because we're doing online assessments. And probably one of the other more important things to think about is the mental health burden that is related to this. You heard a little bit this morning about anxiety. Dr. Diddick would have talked about anxiety. These are all things that can, although it's not directly Parkinson's, it can still affect your symptom profile. I'm going to pause here for a moment. Does anyone have any comments? Other things that they're aware of, or just want to complain about your clinical team and why you don't have access to your neurologist? You can yell at me, it's okay. Even though I'm not your neurologist. Any comments? Any other challenges that we could be trying to address? Keep in mind that PSSO is there as your advocates, right? That's what they do best. Yeah?
One of the difficulties that I have found is actually finding a neurologist within the next 18 months.
Yeah, the waiting lists is an issue, right? Usually when I do these types of talks, we strongly recommend that you try and find a movement disorders specialist. But and do you live locally in town?
Yes, I actually live in Heidelberg, so
Heidelberg, yeah.
Technically I live in the area.
Okay. So there are certain ways, and you can see care spaces on my slides. We do have links. We can probably talk about this after, but if you're having difficulty, for sure PSSO has a list of neurologists that you can access. There are people like me that can help get you in to see a neurologist sooner. And I know it's not ideal to have to go out of town to be able to get that specialty type help, but there are people in town that are being trained in movement disorders now finally, but I'm aware that there's a shortage. We were just talking about even Grand River Hospital has just lost one of their neurologists as well. So there's a backlog across Ontario right now. But if people are having issues, certainly come to speak to someone like myself or reach out to the Parkinson's Society. They'll be able to put you in touch with someone. Any other comments? Yes, there's.
I'm looking at more research in memory and treatment in
Yeah.
terms of memory.
Yeah.
I haven't been able to research much information, and I'm wondering if there's going to be more research in that area.
Okay, so the question, you may not have heard the first part of it, was about memory and whether or not there's treatments and that sort of, is there research being done to be able to figure out how to treat things? And the answer is yes. This is kind of more how I do a support group. So actually, it's set up, thanks for the question, at the right time. My next slide is talking about this group of researchers across the country, and you can kind of see, although I guess I chose the wrong choice of colors, but there are yellow stars that you can see across the country. There's a team of, there's basically 20 sites across the country of something called CCNA, the Canadian Consortium for Neurodegeneration and Aging. And within this group, we are trying to, we're obviously one of the sites, but there's sites across the country. And this is focused on not just Parkinson's, but in fact more on the dementia and the cognitive side of what to do. So you've heard a little bit in the introduction about the Synergic trial. The Synergic trial is basically evaluating 5 different therapies for cognitive decline and trying to see which of those 5 therapies works best. So there are answers, luckily, already coming out from this group. Earlier today, you also heard about some of the gut issues. This, luckily, because we have this team across the country, we are actually collecting samples early on in genetic populations that might be more likely to have Parkinson's, so that we can actually get samples from the gut and track people more long-term, the way that you were hearing just before lunch. The other part of this, of course, and that's why I have this slide up, is that realistically, we are slowly starting to understand that Parkinson's is much more than just a movement disorder. Of course, yes, you see movement disorder specialists, but at the same time, you can see all these different groups. AD is Alzheimer's disease. MCI stands for mild cognitive impairment. And we're getting now to the point where we have started to try and classify people as Parkinson's disease MCI, so sometimes you'll hear your neurologist say PDMCI. PDD is Parkinson's disease with dementia, and then of course there's Lewy body dementia. So in this slide, you can see right in the center that Lewy body dementias in general includes the Parkinson's population, the regular idiopathic Parkinson's. But there's these other types of cognitive groups that we're looking at as well. And across all of these groups, we're attempting to try and do these sorts of treatments. Any other questions? Yeah.
Just a question about the acquisition of data. You've mentioned online assessment. If patients in this room would like to participate and basically describe symptoms, I don't know if you're using sort of a big data approach, or if you're using electronic patient records, or you're using data from patients. So the question really is there a way for patients to participate in some of the research that's going on nationally?
That's a very good question. So certainly the CCNA website, if you were to Google just CCNA, you'd actually be able to see the sites and where you can access these sorts of studies. I also have our contact information on the very last slide. So on the very last slide, you'll be able to see how you can be assessed online from our CareSpace system as well. All good for now? Okay. So when I say that we have this large database and we're collecting samples from across the country, this is kind of the approach that we're taking. And this slide is sort of to deal with gait as an assessment, but in general, a lot of our studies, especially because of the fact that we had been shut down for so long, have been focused on what we would call this prodromal period. So this is a little bit of a complex slide, but when we made this, the idea behind this is if you look at the black timeline, 0 actually represents the time point where you're diagnosed by your neurologist. But notice that the scale goes in both directions here, right? When you see 5, 10, 15, 20, that's 5 years, 10 years, 15 years in one direction as the disease progresses, and you can sort of see by the cartoon figure how the walking is changing to wheelchair over time. But if you go on the negative side of the scale, you can see -5, -10, -15, and one of the things that we are trying to do now is to try and understand what are those early, what we call prodromal markers from the gut, from the way that somebody walks, things that are early like REM sleep disorder, those sorts of things that might give the hint that you are potentially going to develop Parkinson's in advance. And of course, if we could do this, then maybe the treatment regime becomes different because we can attack it before the motor symptoms show up. I'm sure you've heard this many times before, probably from me, but other speakers as well, that by the time you're actually at point 0 on this scale, realistically, you've already lost more than half of the basal ganglia neurons, the dopamine-producing neurons in the brain. So there's a challenge there, and if we could identify this earlier, of course, we would be in a better spot. So the other overlying factor here is that you can see this bridge in blue between clinical care, that's your neurologist and the clinical team that's taking care of you, and the researchers, the people like myself. And you're central to this because we have to understand what things you are noticing, and this is why I always ask you guys to advocate for yourselves so that we know what difficulties you're experiencing. That helps the researchers figure out what things to study, and if we know what things to study, we can drive that research back to the clinical side so that your neurologists also know what to manage and what to try and fix for you. Okay, so I did mention, and this morning you had Dr. Diddick. She's a great speaker. She would have told you about anxiety, right? You had this talk about anxiety this morning. This is just some of our work, and I know that some of you in this room have actually done these types of studies with us. This is a virtual reality example here. You can see in slides A and C. Imagine having goggles on your face. You look down at your toes and you can see your toes virtually through the goggles. And then I ask you to walk across the room, as you can see in slide A, towards that square. And of course, most people do that with no problem at all. Then, in virtual reality, I get in trouble when I try and make people do this in real life. But if you look at slides B and D, the floor drops. And if you look down at this point, it actually looks like you could fall 200 feet to your demise. And in these types of studies, we were very surprised to see how much the symptoms of Parkinson's become amplified by anxiety. Tremor, freezing of gait, as I can show you in this slide. When you're in that low condition and the floor seems flat, freezing of gait episodes happen a little bit. You can see 20 or so freezing episodes. But then look how much that gets magnified just by anxiety. And the point to this is that realistically, anxiety, although it's not really considered a motor symptom or the typical symptoms that you're dealing with in Parkinson's, it can have a profound impact on your symptoms overall. And these are the types of things that are important to communicate to your neurologist and your clinical management team. Okay, the other part of COVID that I wanted to talk about is inactivity. Because we have two linked loops here. On the left, you see cardiometabolic disease. And on the right, of course, you have Parkinson's disease and the symptoms that continue to progress over time. And these two cycles are very linked to physical inactivity. So, of course, this morning you had some experience with the Rocksteady boxing program. You're going to get a little bit more of a movement break after I'm finished talking as well. But this slide is to remind you that, you know, when you end up getting locked in your home because it's not safe. Now, of course, winter's coming, and some of you are going to say that it's dangerous to walk outside because of the ice and the snow and things like that. Keep in mind that being physically active protects you from these two loops of progression. It is true that Parkinson's disease doesn't actually kill you. It doesn't shorten your lifespan. But at the same time, if you're not active, it's these other things in the cardiometabolic loop that can actually cause the longer-term issues. Okay, so of course, exercise is one of those things I'm arguing is very important for you. And the point of this slide is to just show you that regardless of whatever exercise you choose to do, there is, generally speaking, some sort of benefit. What you can see here is 4 different types of programs and then the control condition. And the control condition would have been people coming to meet just in a room to talk, almost like a support group sort of thing. The other 4 groups, as you can see, there is some percentage of symptom improvement related to exercise, whether it's a pool program, strength, or an aerobic program. PD SafeX is something that we've developed and is available through CareSpace. SafeX stands for Sensory Attention Focused Exercise, and I know some of you have been involved in these sorts of studies already. But my point really of putting this slide up is to make sure that you realize that doing something is better than nothing. And all of these, over a 12-week period, you can see at least a 10% improvement in the motor symptoms of Parkinson's. So I want to talk about a few things here. One, we just started talking a little bit about anxiety. It is important to realize that sometimes exercise can contribute to that part. You know, there are of course, medications that you could talk to your neurologist about if you feel like that's contributing to your symptoms. But at the same time, things like PD SafeX and probably some of the other programs as well have been shown to reduce anxiety in Parkinson's. And these are, I'm sort of highlighting these studies because this is the types of things that we would have done during lockdown, as these are the latest publications. So this would have come out just, I think, within the last couple of months. A sensory-focused exercise improves anxiety. And the other one that you can see on here is, this is Kishri again, the PhD student, where we compared boxing to PD SafeX. And this is one of those things, and you know, if you're Googling, and I know lots of you like to Google, it is important to make sure that the sources that you're reading are backed by clear research. And the gold standard that you should always look for is double-blinded, randomized clinical trial. That usually is the best standard that you can judge whether or not something really is of benefit or not of benefit. And then, of course, you know, it also depends the type of journal source that the research is published in. So in this case, and I'm going to deal with this carefully because we've already had some discussion about this at my table during lunch. If you look at this slide, what I'm showing you is time 1, where this is before the exercise program would have been delivered, okay? And basically what you're seeing is the symptom profile of 2 different groups. And then people would have been randomized into getting the boxing program or the PD SafeX program. And the groups were basically equal. That's what you can see at the start from the blue line and the green line. They start at the same point at time 1. Everyone agree with that? Okay. So at time 2, this is 10 weeks later. And 10 weeks later, we would have reevaluated the same group of participants. We didn't know which program they had received. We evaluated them blindly without knowing which program. And what you can see here is actually quite interesting, because the blue line, which is the people that received the boxing, it appears that they've actually gotten a little bit worse. Now, what I want you to keep in mind here is that the normal progression of Parkinson's disease, of course, is for the symptoms to go up, right? So, you know, the worry, of course, is, does this mean that doing boxing is going to make me progress faster? Answer is no. Does the regular progression of Parkinson's disease continue? According to this study, the answer would be yes. If you look at the green line, you can see that the symptom profile has actually improved from time 1 to time 2. That's 10 weeks later. And that's telling us that, of course, the symptoms have actually improved over the 10-week period. Potentially just as important is the question of what happens when you stop that program. Do you keep those benefits, or do you go right back to where you were at time 1? And what you can see here is potentially the more important part, because the progression that happened in the boxing group, whether it's the normal progression or something to do with the boxing program, you stay at that level, wherever you were. So if you got worse, you stay worse. But I should be clear here that this is not significant worsening. This is likely the regular progression of Parkinson's. If you get benefits, as you can see with the green line, in the green line, you keep those benefits for another 10 weeks later. Beyond that, we don't actually know the answer, but that means over a period of 20 weeks, which is, you know, close to half of a year, you're getting benefits that you can actually maintain and keep for a while. If I could keep you guys exercising forever, of course I would. Okay, so we know that PD-SafeX reduces motor symptoms. There's studies that have shown that it improves balance. But the one thing related to COVID that we were very concerned about is that it doesn't seem, or it hasn't seemed in the past, to help with cognitive function. And of course, because cognitive function was one of the things that we were very concerned with over the COVID shutdown, we wanted to know if there was a way that we could actually improve cognitive function as well. So here comes the answer to your question from before. So I'm going to share this one study briefly because we were trying to figure out, one, if we could improve cognitive function, but at the same time, we were also trying to figure out, if we're not allowed to see people in person, how else do we get this program out? And at the same time, for people that live in Heidelberg and people that live in Owen Sound, if you don't live close to a center like the Toronto Western Group or our center in Waterloo, how do you access these types of programs? Can it be done online instead? So in this case, what we tried to do is we delivered these programs online. And again, I know there's people in this room that would have been from London and Strathroy that would have accessed our programs that we were running locally. And we tried to evaluate whether or not we could get the same symptom improvements that I just showed you in the previous slide. So we had, and I already warned you about this, the normal standard should be randomized, double-blinded control trial. In this case, you cannot do that. It's impossible because you know that you're delivering online to these people. We wanted to make sure that everyone had access to the treatment. So in this case, realistically, this is an open label trial, and we couldn't be blinded to who received the treatment and who didn't receive the treatment. Everybody got the treatment, and we knew it. So we have to take these results with a grain of salt, of course. So we did this program. We would have compared 20 people that received the program online to 73 people that did the program in person. It was the same 12-week program. We would have evaluated people just as I described before the exercise program, after the exercise program for motor symptoms. We also did 3 tests of cognitive function to see if we could get those same benefits online as we do in person. And good news, as far as that UPDRS score is concerned, you can see that both groups, whether in person or online, they start at about the same point, and you can see that decreasing slope of the line, which tells you that there is actually a significant improvement, even if you do exercise online. And while we still run programs in person until COVID shuts us down again, we do also have these programs available online with knowing that we can actually get these sorts of symptom improvements. The more important point for us at the time that we were shut down is, could we improve cognitive function as well? So online, you're getting this 20% sort of improvement compared to about a 15% in person. As I said, it looks like online may have had more of an impact, more of a benefit, I guess. But keep in mind that this is an open label trial, so we're not blinded, and we know that we're expecting people to improve, so there could be a little bit of a bias here that makes it look like online's better than in person. The other part of this is, of course, when we started this research, we were aware that people seem to have progressed. Their Parkinson's symptoms were worse, their cognitive function was worse than the previous times that I had seen them, but that was because of the lockdown as well. So it's also possible that maybe in a population that had deteriorated quicker, that they had more potential to improve because their symptoms were worse at the time, being inactive for so long. The other news is on the cognitive front. So some things appear to improve. MoCA is something called the Montreal Cognitive Assessment. I'm sure many of you have done that. You don't get very much of an improvement in global cognitive function, but one of the primary cognitive impairments in Parkinson's is something called executive function or planning, trying to figure out what steps to do things in a row. So if you're making a sandwich and you forget to put the butter on the bread before you put the meat in the middle of your sandwich. Figuring out those steps or remembering to go get your keys before you get in the car, that's what we would call executive function. And in fact, what we saw is this 27 to 39% improvement in cognitive function with the online program. And that gives us great hope that we can actually combat some of these cognitive issues as well with exercise. Okay, so my summary at this point is, obviously COVID has changed things for us. It's changed the progression, both cognitively and motor symptom-wise. It's changed how your clinicians manage your symptoms. It's changed how we assess Parkinson's disease. Most of us advocate for patient-centered care, which means you and your caregivers in many cases, need to take an active role in advocating for yourselves. And that means that if you know your neurologist is only going to have 5 minutes with you, you come prepared, and I know I say this to many of you, you make a list of questions and say, we're starting with this. I need to have these things answered before my appointment is over. That is the best way to make sure that everything that you want to address is addressed in your appointment. The second thing on here is to be aware of how you can help with your own care. Seek out advice, reach out to the Parkinson Society, see if there's other things that you can be involved in. The support groups are a wealth of information. There's centers like ours that help you, I guess for those of you who don't know what CareSpace is, I basically, at the time that the university had shut down due to COVID, I pulled back many of my own students that had graduated, gone on to become physios and chiropractors and nutrition specialists, and had all trained with me in Parkinson's. I brought them back to CareSpace locations so that we'd be able to see our patients through CareSpace instead. And that means that we've got a centralized team that are experts in Parkinson's for speech and nutrition and exercise and everything else, all in one location. So our goal in time right now is to expand across Waterloo, Wellington region. But in time, and again, we were talking about this over lunch, ideally we would see these locations across the province all along the 401, that you should be able to have this type of care wherever you go. So being aware of how you can be involved in your care, seeking out the right resources to help yourself is something that I would advocate for. And finally, of course, exercise clearly is an important part of your prescription, not just the medications, but exercise and taking the holistic picture of everything that you can do to manage your symptoms. So I'm going to stop there early so that if there's questions, and I know there's usually lots of questions, we can deal with them. Thank you for listening.